If you or someone you love is taking medication regularly, and that applies to the majority of people over 60 in this country, then what we're about to share is something that deserves your full attention. There are 9 categories of commonly prescribed and commonly used medications that medical researchers and neurologists have been studying closely for their potential connection to cognitive decline, memory problems, and in some cases an increased risk of dementia over time. These are not obscure drugs. They are medications that millions of people take every single day, often for years, without any awareness that the very medication meant to help with one problem may be creating a different problem quietly in the background. Stay with us until the end, because the 9th medication on this list is one of the most widely used substances in the world, and almost nobody connects it to brain health. Before we get into the specific medications, it's important to establish the right context for everything we're going to discuss. The relationship between medications and cognitive health is complex, and the word linked is doing important work here. When researchers say a medication is linked to cognitive decline or dementia risk, they don't always mean the medication directly causes dementia in the way that a virus causes an infection. What the research often shows is an association, meaning that people who take certain medications over long periods tend to show higher rates of cognitive problems than people who don't, and that in some cases stopping the medication is associated with improvement in cognitive symptoms. The mechanism behind this association varies by medication, and we'll go through those mechanisms as we cover each one. The goal of this video is not to cause alarm or to suggest that anyone stop their medication without medical guidance. It is to make sure that people who deserve this information actually have it, so they can have informed conversations with their doctors. The first category involves a class of drugs called anticholinergics, and this is perhaps the most extensively researched category in relation to dementia risk. Anticholinergic drugs work by blocking a neurotransmitter called acetylcholine, and they are found in a surprisingly wide range of medications including certain antihistamines used for allergies and sleep, certain bladder medications used for overactive bladder, certain antidepressants, certain medications for stomach cramping, and certain medications used for Parkinson's disease. The reason their connection to cognitive health is so significant is that acetylcholine is one of the primary neurotransmitters involved in memory and learning. In fact, one of the characteristic features of Alzheimer's disease is a profound deficit in the acetylcholine system. Medications that block acetylcholine therefore work directly against the very brain chemistry that supports memory and cognitive function. Multiple large studies have found that cumulative use of anticholinergic medications over months and years is associated with a meaningfully increased risk of dementia in older adults. A landmark study published in JAMA Internal Medicine found that higher cumulative anticholinergic exposure was associated with a significantly increased risk of dementia, and this effect was dose-dependent, meaning more exposure was associated with greater risk. For older adults taking any medication for allergies, bladder control, sleep, or stomach issues, it is worth checking with a doctor or pharmacist whether that medication has anticholinergic activity. The second category is benzodiazepines, which are medications used for anxiety, panic disorder, insomnia, and in some cases seizures. Common examples include medications like diazepam, lorazepam, alprazolam, and others in this drug family. Benzodiazepines work by enhancing the activity of a calming neurotransmitter in the brain, and they are effective for their intended purposes in the short term. The concern with long-term use, particularly in older adults, is that benzodiazepines have been associated in multiple studies with an increased risk of dementia and persistent cognitive impairment. The mechanism involves the fact that these medications reduce the electrical activity of the brain and can impair the memory consolidation processes that normally occur during sleep. Chronic long-term use can also lead to dependence and withdrawal that further stresses the brain's regulatory systems. Several large population studies have found that people who used benzodiazepines regularly for extended periods had significantly higher rates of Alzheimer's disease diagnosis compared to non-users, though researchers continue to debate whether this reflects causation or a more complex relationship. What is clear is that for older adults in particular, long-term regular benzodiazepine use carries enough cognitive concern that many medical guidelines recommend against it. The third category is sleep medications, specifically the class of drugs sometimes called Z-drugs, which includes medications commonly used for insomnia. These medications work on similar brain receptors as benzodiazepines and share many of the same concerns. Research has associated regular use of these sleep medications with impaired memory consolidation, next-day cognitive fog, and in studies following people over longer periods, a potential association with dementia risk. The irony is significant because poor sleep is itself a risk factor for dementia, meaning the goal of treating sleep problems is genuinely important, but the method of treatment matters enormously, and medications that sedate the brain rather than supporting natural sleep architecture may be working against cognitive health even as they address the immediate sleep complaint. The fourth category involves certain blood pressure medications, specifically an older class called beta blockers, some of which can cross into the brain and affect neurotransmitter activity there. While blood pressure management is critical for brain health and uncontrolled high blood pressure is itself a major risk factor for vascular dementia, certain beta blockers have been associated in some studies with depressive symptoms, cognitive slowing, and in some cases memory complaints, particularly at higher doses. Not all beta blockers carry the same brain-penetrating properties, and this is an area where the specific medication matters significantly. The message here is not that blood pressure medications are dangerous, they are often essential, but rather that the specific choice of medication and the dose being used are worth discussing with a doctor in the context of cognitive health, particularly if you have noticed any memory or mood changes since starting this type of medication. The fifth category is proton pump inhibitors, commonly known as PPI medications, which are widely used for acid reflux, heartburn, and stomach ulcers. These medications are available over the counter as well as by prescription, and they are among the most commonly used drugs in older adult populations. The potential connection to cognitive health is less intuitive than some of the other categories, but research has suggested several possible mechanisms. PPI medications reduce the absorption of certain nutrients including vitamin B12 and magnesium, both of which are important for brain health. They also alter the gut microbiome in ways that may affect the gut-brain axis, which is an area of active research in neurology. Several observational studies have found associations between long-term PPI use and increased dementia risk, though this research is ongoing and the relationship is not yet fully established. For older adults taking PPI medications daily for extended periods, discussing whether continued use is necessary and whether the dose can be reduced is a reasonable conversation to have with a doctor. The sixth category is statin medications used for cholesterol management, and this is an area of active and sometimes contentious debate in the medical research community. Some studies have found associations between statin use and cognitive complaints or memory problems in certain individuals, and the FDA has required that cognitive impairment be listed as a possible side effect of statins. However, other research has suggested that statins may actually be protective against certain types of dementia. The current scientific picture is genuinely mixed, which itself is important information. For people who notice cognitive symptoms that seem to have developed or worsened after starting a statin medication, raising this possibility with a doctor and discussing whether a trial pause or alternative might be appropriate is a legitimate conversation, particularly since the cognitive side effects, when they do occur, appear to be reversible upon stopping the medication in many reported cases. The seventh category is certain antidepressants, particularly the older tricyclic antidepressants and some other antidepressants with significant anticholinergic properties. These medications are used for depression, anxiety, nerve pain, and in some cases sleep, and they have real and important benefits for many people. However, their anticholinergic activity means they carry some of the same cognitive concerns discussed in the first category. Newer antidepressants with lower anticholinergic burden have a better cognitive safety profile for older adults, And if you are taking an older antidepressant and have concerns about memory or cognitive function, asking your doctor whether a medication with lower anticholinergic activity might be equally effective for your situation is a reasonable question to raise. The eighth category is opioid pain medications, which affect the brain through opioid receptors found throughout the central nervous system. Research has associated regular opioid use with cognitive impairment, and the mechanisms are multiple, including direct effects on brain function, disruption of sleep architecture, and in longer-term use, changes in brain structure and neurotransmitter systems. For older adults managing chronic pain with opioid medications, this is not an argument for undertreating pain, which has its own serious consequences, but rather for ensuring that pain management is as comprehensive as possible, that non-opioid strategies are being used alongside or instead of opioids wherever feasible, and that cognitive function is being regularly monitored. The ninth medication category, and the one that surprises almost everyone, is the regular use of over-the-counter antihistamines, particularly the older generation antihistamines found in allergy medications and many nighttime cold and flu remedies. These medications are sold without a prescription and are taken by millions of people as though they are completely harmless because they don't require a doctor's visit. But older generation antihistamines are potent anticholinergics, meaning they fall into the very first category we discussed, the one with the most concerning and most established research connection to dementia risk. People who regularly take these medications for allergies, colds, or sleep, sometimes for years without ever questioning whether long-term use is safe, may be accumulating significant anticholinergic exposure without any awareness that this is a concern. The newer generation antihistamines, which are also widely available over the counter, generally do not cross the blood-brain barrier and do not carry the same anticholinergic concerns, making them a meaningfully safer choice for regular use. Now let's talk about what this information actually means in practical terms, because understanding it is only useful when it leads somewhere actionable. It's also worth taking a moment to understand why older adults are specifically more vulnerable to the cognitive effects of these medications compared to younger people taking the same drugs. Several biological changes that occur with aging make the brain significantly more susceptible to medication-related cognitive effects. First, the blood-brain barrier, which is a protective filtering system that controls which substances can pass from the bloodstream into the brain, becomes somewhat more permeable with age, meaning more of certain medications can actually reach brain tissue than would in a younger person taking the same dose. Second, the brain's own compensatory mechanisms for managing chemical imbalances become less robust with age. A younger brain can often tolerate some degree of neurotransmitter disruption and compensate fairly effectively, while an older brain with less neurological reserve may show noticeable cognitive effects from the same disruption. Third, older adults typically take more medications simultaneously than younger adults, meaning the potential for combined anticholinergic load and drug interactions affecting the brain is substantially higher. And fourth, the liver and kidneys, which process and eliminate medications from the body, work more slowly in older adults, meaning medications stay in the system longer and at higher effective concentrations than the standard adult dose was designed for. Another dimension worth understanding is the concept of drug-induced cognitive impairment versus genuine dementia. Not all cognitive changes caused by medications represent the beginning of permanent dementia. Some medications produce cognitive effects that are genuinely reversible when the medication is stopped or the dose is reduced, and recognizing this distinction is critically important. When an older adult begins showing memory problems, confusion, or cognitive decline, one of the first questions a good clinician should ask is whether a medication change could be contributing, because in many cases what looks like early dementia is actually drug-induced cognitive impairment that can be partially or fully reversed with appropriate medication adjustment. This is one of the reasons why medication review is such an important part of dementia evaluation, and why an older adult presenting with new cognitive symptoms should always have their complete medication list reviewed by a knowledgeable clinician before a diagnosis of progressive dementia is assumed. The relationship between sleep quality and this entire picture is also worth highlighting explicitly. Several of the medication categories we discussed disrupt sleep architecture in ways that compound their direct cognitive effects. Benzodiazepines, Z-drugs, opioids, and many anticholinergic medications all suppress certain stages of deep sleep or REM sleep, and these sleep stages are precisely the periods when the brain performs its memory consolidation work and clears metabolic waste products through a system called the glymphatic system. The glymphatic system is essentially the brain's overnight cleaning mechanism, and it requires deep, natural sleep to function properly. When medications chronically disrupt this natural sleep architecture, the brain accumulates metabolic waste that includes compounds associated with Alzheimer's disease pathology. This means that the cognitive harm from these medications is not just from their direct pharmacological effects on brain chemistry, but also from the indirect effects of chronic disrupted sleep on the brain's own maintenance and cleaning systems. The first and most important practical step is to never stop or change any medication based on a video or any source of general information without discussing it with your prescribing doctor first. Many of the medications we have discussed are being taken for serious conditions, and stopping them abruptly or without medical guidance can cause significant harm. The purpose of this video is not to prompt anyone to make unilateral changes to their medication regimen. It is to equip you with information that makes you a more informed and more active participant in conversations with your healthcare provider. The second step is to ask your doctor or pharmacist for a comprehensive medication review that includes an assessment of the overall anticholinergic burden of all the medications you are currently taking. There are tools that doctors and pharmacists can use to calculate the cumulative anticholinergic load of a medication regimen, and for older adults taking multiple medications, this cumulative burden can be significant even when no single medication seems particularly concerning. The third step is to report any cognitive changes, memory complaints, or mood changes that seem to have developed or worsened since starting any medication, rather than assuming these changes are simply part of normal aging.